I want to talk about our work on pathways to healthy aging and how lifestyle, genetics, and environment interact to promote resilience against Alzheimer's disease in African Americans. You might ask, why do we focus on African Americans? Well, there are three reasons. As compared to white Americans, African Americans are twice as likely to get Alzheimer's, 50% less likely to participate in research, and less likely to seek and receive treatment. And so our overall target goals are to address all three: reduce Alzheimer's in the Black community, expand participation, and to increase treatment. Our program, we call it In the Community, Pathways to Healthy Aging in African Americans, and it's actually a suite of different studies, primarily a longitudinal study. Since 2015, over 850 older African Americans from Greater Newark have joined our programs for two reasons. One, they joined to improve their own brain health and reduce their risk for dementia. It's very much a health education and promotion program, and at the same time, they support research on healthy aging as a participant in our studies. Who is eligible? They identify as African American or Black, age 60 or older, speak English fluently, and are willing to return every year. And the vast majority are cognitively healthy on enrollment, although now we're beginning to enroll some people with MCI and mild AD to have a clear understanding of what that terminus looks like. To give you a sense of who these people are, almost half of them they live primarily in East Orange and Newark. Almost half of them live in federally subsidized housing, public housing, and Section 8 housing. So almost half are below the federal income line. This is within Newark. This is a heat map showing violent crime throughout Newark. You can see our university is in a slightly sort of safe middle zone. A lot of our participants mapped onto this map you see in some of the higher crime areas. You get to see something about the sort of the neighborhoods in which they live. Education ranged from 6 years to 20 years. A third of the people have high school or less, and about half have an associate's degree or some college, but we do have some with postgraduate training. Almost 60% are pre-diabetic or diabetic, and similarly high rates of obesity and hypertension. So in a broad range of ways, this captures the sort of the reality of the demographics of urban African Americans, especially in the low income areas. Which brings me to talk about diversity. There's no cross-racial diversity, what we call checkbox diversity. Everybody checks the same box, African American or Black. And what that means is we focus on intraracial diversity across a broad range of variables that define the very many communities that are within the African American communities. And this brings you up a dirty little insider secret, which is that when you talk to people at ADRCs, I don't know about yours, the small numbers of African Americans who are recruited into most ADRCs and into most pharmaceutical clinical trials, not only are there a small number, but they're predominantly higher educated and from the upper economic strata who are associated with the university medical systems where the ADRCs are based. So actually, the small numbers of African Americans are often healthier than the average white participants because they're culled from this sort of small strata. So we have not only a large cohort, but we have one which is highly diverse and representative of the community's many health comorbidities. How did all these people come to participate in the Rutgers Pathways study? We've been working in the community for 18 years. The first half was just community engagement only. It was a public health education program that I ran. And then in 2015, we shifted to building on that relationship to start to do research. So in 2 years, we're going to have our 20th anniversary gala, and I assure you it will be a party not to be missed. Our community engagement team is led by a senior leadership, Glenda Wright, who oversees all of our housing, Reverend Wilson oversees our church relationships, and Dolores Hammonds, who oversees our participant satisfaction and retention. She makes sure everybody is happy. These three people bring 200 years of collective experience with local African American communities, and they are the primary drivers of the decision-making of what we do. They're supported by almost half a dozen other older members of the African American community who work on various subsets of the different communities that we work with. And I use communities explicitly because there's so many different communities that we work with within the Black communities. They're paired with students, undergraduates, and graduate students, a lot of public health students who often are paired with them when they go out into the community to do a mixture of sort of health education and explaining about the science and the research. So overall, we have about 15 people actively doing community engagement to build our cohort. Much of what we do are programs we call Aging Smart. They're lunch and learns at churches and public housing residences. The one thing everybody wants to know, is there anything I can do to reduce my risk for Alzheimer's disease? We say there are 6 things you can do. These are the 6 things. There's you've all seen them before. If you have trouble remembering 6 things because you have a memory disorder, that's no problem. We have a magnet you can put on your refrigerator to help you remember them. We expand on that in a brochure that we distribute widely at all of our events that provides more details on the 6 steps and how to make them part of your life. Three times a year, we publish a newsletter, and I have some of them here for the 4 of you who are here in this office, and others tonight. It's a newsletter that covers both the work that we do, news you can use, tips, testimonials from participants and community leaders, healthy cooking tips, and also information about our studies. And we print about 5,000 a year. We mail them, they're distributed to all of our participants, so they hear from us 3 times a year and at all of our community programs. We use what we call old-fashioned social media. It's known as radio. And this is one example. See if you can hear it.
To do, and exercising and eating correctly is one of the most important things that you can do. Sleep. We need to get sleep.
So that's our form of social media. A key long-term partner for us is the Newark Housing Authority. We've been working with them from the very beginning with support from the mayor and the leadership from HUD. Glenda Wright, who I mentioned before, has worked for over a quarter century doing tenants advocacy for the housing authorities, and we work with her.
This type of event is so necessary for all of us, because maybe one day we can put Alzheimer's behind us.
We have a monthly meeting of our community stakeholders boards. This includes over 40 churches, 7 masjids, 13 public housing sites, and a broad range of other health and nonprofits and clinics throughout the area. We gather for a meeting first, and then we have a luncheon. The luncheon is always catered by the oldest and best Jewish deli in Newark, which is why it's often known as Pastors and Pastrami on Wednesday. Our current participants recruit their friends. So at this point, a quarter of all of our new participants come by word of mouth, not by anything we do, but by talking to their friends. You might ask, what do they say to their friends?
I give them the background of saying, this is something that's very prevalent in our community. Your mental health is important.
Men are a pain in the ass. Originally in 2016, only about 7% of our participants were men because we just did broad outreach to communities. Churches, that's about the percent of men who show up at services on Sunday in most of the churches. This clearly wasn't going to cut it when it comes to NIH's sex as a biological variable, one of our key deliverables. So we've had to really create an entire program. And now we have about 25% of our new enrollees are men, and our goal is about 35%, which is approximately matches the 2-to-1 ratio in the community of women to men, because so many men sort of die young. How do we do that? We have a multimodal targeted outreach to older Black men. We don't just do one thing, we do a lot of things. We have special programming focused on athletics and cars. The problem is, men, we think we know everything and we think we're invulnerable. Therefore, why do we need to learn anything, and why do we need to protect ourselves? So we basically have to sort of come in on the side with other interests to men and then kind of hit them on the side with some unexpected health information. This is one of the ways we do
So we're having a classic car show and men's brain health fair combined for the first time here at Rutgers University-Newark. And the purpose is to reach out to men who traditionally don't come to health education events with local churches with their men's ministry.
We partner with local church men's ministries. We do Saturday morning senior men's health and wellness breakfast. There's Reverend Wilson on the right. We partner with the imams of the local mosques. In contrast to the churches, which are mostly female attendants, the mosques are mostly male attendants. So it's a rich source of reaching out to men. We're celebrating here the end of Ramadan with some of the local imams with a halal luncheon that we do every year. We work with the Black college fraternity alumni groups. These are sort of called the Divine Nine, the fraternities of the sororities. They're a way to reach out to, of course, a higher socioeconomic and educational demographic throughout the region. And we work very actively supporting post-incarceration reentry. A significant number of older Black men are incarcerated, are released every month, and we work with support programs to help them with reentry, with housing, with tech training. We have student senior tech support breakfasts where we help train people on smartphones that didn't exist 30 years ago when they left society. And we've hired some of the people from this group to come work with these programming. So it's one of our many different sources of men. So the bottom line from all of this is that there's no quick, easy, or cheap way to recruit older African Americans to aging and brain health research. And I say this clearly because everybody comes to me and says, so can you tell me a quick, easy, or cheap way to do what you do? And the answer is it doesn't exist. So everyone who joins our program is known as a VIP. We treat them as a VIP. We call them a very important participant. What do they do during what we call the Rutgers brain check? Well, on day one, they do about 30 minutes of the medical school, saliva for genetics, blood tests for brain health, immune, diabetes. Day two, they come in for cognition, health, fitness, and lifestyle assessments. We also do a broad range of standard neuropsychological assessments that I'll throw up and then take down. We do brain imaging, MRI brain imaging on a 3 Tesla Prisma. And optional, we do 4 days of home EEG sleep monitoring so that we're getting a really detailed quantitative measure of their sleep. They can earn up to $250, and then they come back every year. We used to do it every 2 years. We've now shifted to every year. So more in line with what happens here and at other ADRCs. As of April 2024, we logged over 1,200 testing visits, which are each 2 to 3 days each. So what if a VIP shows signs of possible MCI or dementia? If dementia is suspected, we refer to clinical evaluation. We have a clinical neuropsychologist on our staff. We do a broad range of blood tests, probably similar to what most ADRCs do to rule out other possible comorbidities. And then Michelle does a whole other battery of extensive neuropsych assessments, a clinical interview, meets with informants, and then we get a clinical evaluation. So that's our trajectory. Once people are diagnosed with dementia, we provide them with support and care to direct them to a variety of health clinics. We're not a hospital, and we also run monthly support groups for dementia caregivers, who, as you know, are often the most deeply affected by the dementia. What do we hope to have learned from the participants who've joined? This has all been sort of a background on our sort of recruitment in our cohort. There are 4 key knowledge gaps that motivate our work. Early detection, how do we detect the earliest phase of Alzheimer's? Risk and resilience, how do genetics, environment, and modifiable lifestyle factors interact? Personalized, low-cost, non-pharmacological interventions. We don't do drug trials. What we're looking for are ways in which health and lifestyle or low-cost interventions can be applied everywhere, easily and inexpensively, to help people. And how can we ensure that whatever these advances are, these in knowledge as in interventions, benefit those most in need, especially African Americans? Let me start by talking about early detection. As John had mentioned, a number of years ago, we developed a series of generalization tasks, which we've argued identify early cognitive decline years before dementia. By the time someone is diagnosed with Alzheimer's, 80% of the brain damage has already occurred. But this is where we really want to be when there's a problem, when the brain is still largely healthy, because that's where any intervention, pharmaceutical or otherwise, is most likely to have the most benefit. What we've discovered is that the earliest cognitive changes are not to memory loss, this is the standard Alzheimer's syndrome, but the loss of the ability to flexibly apply, that is to generalize learning from one situation to another. Generalization is the transfer of past learning to new situations. So here, if I learn that broccoli in one trial makes me sick, I'm going to avoid broccoli in the future. The question then is what happens when I see cauliflower? Cauliflower is similar to broccoli, but not exactly. So the question is, do I eat it or do I avoid it? And that's the fundamental challenge of specificity or discrimination in generalization. Animal and human studies show that damage to the hippocampus impairs generalization of learning. So there's the hippocampus in red, schematized. If I damage the hippocampus, it doesn't really impair your ability to learn a simple association, like broccoli makes me sick, but it impairs your ability to generalize. And the way it impairs your ability to generalize is that it alters the way the original memories are stored, how they're encoded. So that how you encode a memory determines what you think is or isn't similar to it, and that affects generalization. We described this in a computational framework in 1993, a Gluck and Myers paper, and then a book, a neural network model of the hippocampus and associative learning. It was essentially a machine learning approach to understanding the entorhinal cortex and the hippocampus and other structures and the role they play in encoding information. The key idea is that how new memories are represented by the hippocampus, essentially the encoding scheme, is what determines generalization, because how I encode an event determines what is or isn't similar to it. Our computational model suggested a functional dissociation of subregions. This encoding that we've described, we argued actually primarily it describes the entorhinal cortex and the dentate gyrus. And that's distinguished from traditional views of the hippocampus, which focus on episodic or event memory storage, which are more likely mediated by CA1, CA3, subiculum, other brain regions. So we were arguing for a functional dissociation within the medial temporal lobe between encoding and episodic memory. This became relevant as we began to learn about Alzheimer's, because the time course of Alzheimer's starts first in these encoding regions, the parahippocampus, the entorhinal cortex, and only later in the progression of the disease does it affect CA1, CA3, the regions we argue are what you're seeing in episodic memory storage. Now that's relevant from a clinical perspective. So what we argue is that the earliest pre-symptomatic or preclinical AD may only affect representation and generalization of learning, but not episodic event memory storage. And that's important because all the standard neuropsych tests that are used at memory clinics and in doctors' offices are measures of episodic event memory storage, mini mental state, auditory verbal learning tasks, delayed paragraph recall. Fundamentally, these are all tapping in to the CA1, CA3 regions, which are damaged in symptomatic Alzheimer's, but are probably not affected at this preclinical phase. So here's an example of one of the tasks. It's being one of the two. We have a number of them, two of them in particular, that are in fact being used here at USC. We might ask subjects, where's the hidden smiley face? They guess yes, they're correct. In a transfer phase, there's something they haven't seen before. If they guess correctly, they get positive feedback. The rules stay the same from phase 1 to phase 2, so the rules don't change, but the relevant features change. And half the rules are shape rules, half the rules are color rules. So the idea is that all the patterns in phase 2 are novel. You could approach it as an entirely new problem and start from scratch, or you could import your learning from phase 1 and generalize it to phase 2 and get a head start on what's going on in phase 2. Some earlier work we had done on hippocampal atrophy. So these are cognitively normal adults from the NYU ADRC who either did or didn't have some degree of mild hippocampal atrophy. So pink is hippocampal atrophy. Again, these are all cognitively normal. What we showed back in 2002 was that those with hippocampal atrophy showed no deficits on learning. This is errors, so big high is bad. But on transference, on generalization, they show a lot of errors on phase 2, while those with no hippocampal atrophy show very few errors. They've generalized. In contrast, delayed paragraph recall is normal, and that's why these people are described by the ADRC at NYU as being cognitively intact, because they show normal delayed paragraph recall. So the bottom line here is we've argued that it's these errors in generalization that are most symptomatic of preclinical AD. So it's generalization, not learning, and not memory recall, but generalization of learning. Still healthy, the work we've done here at USC with John, my host. There are several well-characterized genes that have been identified that 100% predict the future of AD. It doesn't matter if you get up in the morning and do 6.5 miles in the hills, you're still going to get it if you have these genes. Early onset familial AD or FAD, only about 2 to 5% of AD cases are this. So it's very rare, and so we're grateful to John and his colleagues for access to these patients. People with FAD will show signs of dementia in their 50s. So what's unique about this is we know these people will get Alzheimer's. So unlike in our longitudinal study where we're following people 2, 4, 6, 8 or more years to see who gets declines, in this case of this, we can look at people and know who will or won't get Alzheimer's. So here's the sort of the bottom line from a study, the first paper we did with John. It shows that we're comparing people with the mutation to their kins who are non-carriers. You can see learning, there's no deficit. In generalization, that the only deficit is novel pairs with those with the mutation. So we replicated the same finding in John's population, and some other data we showed that across both groups, carriers and non-carriers, the degree to which they are impaired at generalization is associated with their hippocampal volume. So once again, suggesting this is a hippocampal related phenomenon of how they encode and then generalize. Longitudinal studies, we did some early longitudinal studies and showed that if we look at people at one time point here at their diagnosis and then look 2 years in the past at what their generalization score is, we see that those people who were diagnosed 2 years later with MCI or AD were the ones who were scoring the worst, making the most errors on generalization. Those who scored, who had little or no errors, were still normal 2 years later. So that was our first hint that this generalization could be predicting longitudinal decline. But it's a small N, it's only 2 years of follow-up, and it's mostly white, well-educated people from NYU. So the summary, the Rutgers generalization tests are new cognitive markers for detecting early cognitive decline towards future Alzheimer's long before standard neuropsych measures are able to detect any deficits, which leads us to ask what changes in the hippocampus and the medial temporal lobe during these early stages of Alzheimer's to impair generalization. So we do, as I said, we do imaging on most of our participants. We do a broad range of different imaging, and the one I'm going to focus on is resting state fMRI, because that's where we found the most particularly of interest. We measure dynamic medial temporal lobe connectivity. I'm going to define what I mean by dynamic medial temporal lobe connectivity. We do a 10-minute resting state scan. People are just sitting in the magnet. They're not doing any tasks. We divide those 10 minutes into 20 30-second slices. For each slice, we do a graph theoretic and network analysis to measure the strength of connections, because we're measuring the strength essentially not directly, but indirectly based on co-occurrence by synchrony in firing between key subregions. And then we ask, if we look at all these 20 slices that we do, each of them a half a minute, how similar are these networks throughout those 10 minutes, or are the networks changing around? And what we find is that rigid connectivity, so the same regions are in synchronous with other subregions, is associated with cognitive decline. That flexible dynamic connectivity, where subregions are connecting and then reconnecting and they're sort of asynchronous across it, is associated with healthy. That's where you want to be. So the idea here is that we could think of this as being like at a party, assuming you're an extrovert, that social connectivity, a good party, is a fun cocktail party where you're talking to lots of different people and you're bopping around to having conversations. Rigid social connectivity is like a boring dinner party where you're stuck talking to the same person at the same little table in a corner all night long. So we want flexible social connectivity at a cocktail party. We want flexible brains. So in summary, medial temporal lobe dynamic network connectivity is an innovative new biomarker for AD risk. It uses resting state fMRI to evaluate brain circuits in the medial temporal lobe. These two tools, which have been sort of a key part of what we've been doing, now we can begin to apply them to ask about risk and resilience. I'll start to talk about sleep. Here we see a main effect. This is self-reported sleep. We're looking at dynamic flexibility. You see that those people in our cohort who report very good sleep show the highest level of flexibility. Those with poor sleep, more rigid, less flexibility. So suggesting this flexibility is sort of mapping on, capturing something going on in sleep, which leads us to ask, can quality sleep protect the brain health in those who are at high genetic risk for Alzheimer's disease? And I'll explain what high genetic risk I'm referring to here. ABCA7 affects the transporter proteins associated with amyloid, especially AB clearance. There are two SNPs. I'm going to talk about both of them here, but I'm going to start with the one that's most commonly discussed in the literature. It's called ABCA780. It's specific to African Americans. The risk allele is rarely found in those of European descent. Those who have the risk allele, it almost doubles the risk for AD in African Americans. And it's a really important gene because most people talk about APOE, but ABCA7 is much more predictive of AD risk in African Americans than APOE4. African Americans have the APOE4 risk variant, but when they do, it's not very strongly associated with Alzheimer's risk. So, and we see that same relationship between ABCA7 and APOE4 using our resting state measure. ABCA780 variation in our cognitively healthy cohort strongly predicts the flexibility measure in resting state. APOE has essentially no correlation with that. Let me show you two main effects, and then I'm going to divide them up by sleep. So here's the direct impact of this genotype on cognition. So poor cognition and lower flexibility in those who have the high risk variant. So red is high risk. We see a very large N here, 436. Those with the high risk show more errors on generalization. Those with the high risk show lower medial temporal lobe flexibility. So I'm going to focus for a moment on generalization here. I'm going to take this graph and I'm going to spread it across the page and divide people up by their self-reported sleep quality. And what you see is that for the people with poor sleep quality, the effect is even magnified. People with poor sleep quality, there's a huge impact of this genetic variation. By the time you get to people with good sleep quality, the genetic risk disappears. So it suggests potentially that high quality sleep may be neuroprotective against the risk from ABCA7. And that's kind of where you want to be. So good quality sleep eliminates the poor generalization associated with the high risk genotype. Let's go back to this graph here, the brain imaging graph. Move it over to the left, spread it out according by sleep quality. And what you see again is the same pattern. People with poor sleep, there's a huge effect of this gene on their medial temporal lobe flexibility. By the time you get to good sleep, the effect disappears. So again, what we see is that good quality sleep eliminates the medial temporal network flexibility associated, the lower flexibility associated with the high-risk genotype. Some pilot data, we've looked longitudinally. ABC RAVELT is one of these standard episodic memory tasks that's sort of used or indicative of decline to clinical dementia. And what we see here is that people with high risk who have good quality sleep show no change in RAVELT. If anything, there's even a little bit of an improvement over 2 years. While those with poor, so you definitely want to sleep. In contrast, those with poor sleep show a decline over 2 years. So again, it's the gene if you have good quality sleep, you're protected against the decline that otherwise you see in those people with poor sleep. So interim summary, this gene doubles the risk for AD and older African Americans associated with poor cognitive and neural network health. We've shown that good quality sleep can eliminate both the cognitive and the neural network consequences of the genotype, and preliminary data suggests the high quality sleep can offset future cognitive decline in these risk carriers. So this is all self-reported sleep. It's obviously limited both in reliability and in detail. So one of our current directions, as I had suggested earlier, is to use multi-night home EEG sleep monitoring to identify the stages and the properties and the microstructure of sleep oscillations that are predictive of cognitive, neural, and neuropathological measures of AD risk. Sleep is a very complex phenomena. We're particularly interested in non-REM sleep, slow wave sleep, and there's evidence suggesting that sleep spindles, rapid firing during slow wave, may be associated with clearance of sort of triggering microglia and clearance of amyloid in the brain. To sort of pursue that further, we've been using a headband like this, sort of a small mobile EEG. It looks like this on the participants. They can sleep fine. We look at sleep spindle density. Again, if we look at standard neuropsych measures, remember this is a cognitively healthy population, Ravel standard psych measure, you might say, well, on terms of memory, spindle density has no impact. But if you look at generalization, what you see is a completely different story, that in this population, there's an incredibly tight correlation and prediction between sleep spindle density and how well you do at generalization. Again, sleep spindles do not correlate with structural integrity of the hippocampus. That's the atrophy that you might have seen as you sort of move on. Sleep spindle density and left hippocampal volume, no correlation. But if we look at dynamic flexibility, we begin to see the correlation become apparent, that the higher the sleep spindle density, the more flexible these medial temporal networks. So what this suggests overall is that some of these connectivity changes in the medial temporal lobe are probably preceding the structural atrophy, which in turn is then preceding the actual clinical symptoms of Alzheimer's and memory loss that you see later on. We've also been looking now, we've been looking at plasma p-tau, and what we see, as predicted in a small subset of 25, is that the higher levels of higher density sleep spindles are associated with lower p-tau, consistent with the possibility that sleep spindles are critically involved in clearance of amyloid and or tau. So interim summary, higher proportion of slow wave activity and greater sleep spindle density during non-REM sleep may be associated with reduced risk. These microarchitecture features may serve as markers of future Alzheimer's risk, and sleep may therefore represent a possible therapeutic target in modulating risk for Alzheimer's disease, especially in African Americans with this risk variant. So one of our future directions is to continue to extend these preliminary EEG studies. We're working with Bryce Mander down here in beautiful Southern California at looking at some of these sleep spindle studies. And we're beginning to conduct pilot interventional studies with cognitive behavioral therapy for insomnia in people who have the risk allele and have poor sleep to see if we can both improve their sleep, and if so, does that improve their medial temporal brain function and or cognition. That was for a local talk in case people there. Let me turn now to fitness and exercise, one of our other favorite health and lifestyle factors. Perhaps when people say, what's the one thing I need to do? I say, get up early and exercise before breakfast. We measure physical fitness with a 6-minute walk. How far can participants walk in 6 minutes? This is an estimate of maximal VO2 max oxygen consumption. It's important, again, apologies to all the neuropsychologists in the audience. Again, if you were to look at this data, you might say, well, why should I be physically fit? It doesn't improve me on any of the standard neuropsych measures of cognition, delayed recall, MMSE, digit span, no effective physical fitness. Why should I be physically fit? Well, if you look at generalization, that's where you see it. If you look at physical fitness, according to map to generalization, you do see a strong correlation. But what's interesting is you don't see that strong correlation in everyone. Which brings me to the other allele. There's a lesser known SNP called ABCA750. It's found in all races. It's especially, the risk variant is especially found in women, and it increases risk directly only by about 20%. So it's not often discussed in the literature of sort of risk factors. But what we found is sort of a novel finding about this gene is that if you sort the people in our study by this genotype, then you look at the people with the risk genotype, they show no benefit from physical fitness. Having removed those people from our population and look at those with the non-risk genotype, we see an even stronger correlation because we've essentially removed it. So it suggests that the ABCA750 gene modulates the fitness to generalization relationship, and it's only those with the non-risk genotype that are benefiting from this, the non-risk variant. So in summary, carriers of the non-risk variant show a strong correlation between fitness and generalization, but not on standard neuropsych tests. Those with the risk variant show no significant advantage to being more physically fit. The implication is that this genotype may diminish the neuroprotective value of aerobic fitness, which leads us to ask, does the ABCA7 gene also impact the effects of exercise on cognition and brain health within an individual? The previous finding is a cross-sectional finding across individuals. We want to ask the question interventionally within an individual if we change their fitness. That is, can we help these people with, can we help these people with low fitness and low in cognition improve on both? So this brings us to personalized, low-cost, non-pharmacological interventions. Our methods from our earlier exercise study was a 5-month dance-based cardio-aerobic exercise program. It was twice a week, 60 minutes per session, held at local churches, senior centers, and federally assisted housing, and then reassessed people later. This was basically, the cardio was basically Zumba to Motown, is how we describe it. And to better understand it, everybody except for John Ringman should stand up because John has already made it clear he's not going to do it. And it looks like this. You can stand up. We can all stand up here. I'm doing the seated version for the back. Okay, so 5 months of that, 3 times a week. What do we see? As predicted, after 20 weeks of this intervention, only the carriers of the low-risk genotype showed exercise-related improvements. So here we see the data from this paper, which is published. Only those who were in the exercise and had the low-risk variant showed a reduction in errors and generalization. Those in the control group did not. Those in the exercise group with the high-risk variant did not. So we essentially replicated the same pattern. So older sedentary African-Americans with a high-risk variant showed less cognitive benefit. And the implications here is that different people with different genetic variations may require different and personalized prescriptions of exercise. We hear a lot about personalized medicine, genetic-based medicine. This suggests that even when it comes to lifestyle recommendations, there could be a personalized genetic-based recommendations. How does exercise rewire our brains to improve cognition? So what we see is that across the exercise, those in the exercise intervention show increases in medial temporal lobe flexibility, exactly as we would sort of expect from our cross-sectional data. And that sort of suggests that we're making the brains more flexible. Moreover, as similar to what we did with John in the FAD study, across both groups, the exercise who are in orange and the control in blue, the change in generalization, this is the change in errors along the horizontal axis, is highly correlated with the change in flexibility along the y-axis. And what this shows is that in the upper left-hand corner, most of our participants, those in the orange, improved on both generalization and flexibility. In contrast, many of our control participants who had no exercise declined on both measures over 5 months. So it suggests that the cost of being sedentary is apparent in less than half a year. So that should be of concern to those of you who aren't exercising. So summary, exercise promotes medial temporal flexibility and may prevent increases in synchronicity or rigidity across subregions, protecting against cognitive decline. So our prescription is to get down and boogie, which is why we run our soul brain dance parties for our participants throughout the year to help them.
And it punches rampage within our community and within our own family.
We have a clinical trial in R01 for a randomized clinical trial. The previous study didn't have an active comparator group and had a number of other limitations. And the key questions for this ongoing clinical trial that we're doing now is, does exercise prevent? We all know exercise is good. You've been hearing it from everybody. But does it actually reverse the neuropathology, the cell death and damage measured with plasma markers? Or is it just compensatory? And we don't know the answer to that overall. We don't know if whether exercise is just compensatory or whether it's really going to change the underlying pathology. There's no data yet. And how does cardio exercise compare to low aerobic training? So we have a clinical trial with a randomized control. And that's ongoing. And these things are just for the local doctors in the Newark when we give the talk. So the bottom line is, what do we know now about genetics and lifestyle behaviors that we didn't know before? So here's the big picture schematic in your brain. Here's the big picture. So let me just sort of walk you through it. I described first a direct effect of a gene, ABCA780, that's modulated by lifestyle. So direct effect of the gene is modulated by lifestyle. And then I told you about a direct effect of lifestyle that's modulated by another SNP of the same gene. So gene lifestyle interactions in two different ways. And moreover, that to see this in a cognitively healthy population, you need to be measuring brain function, using these resting state measures, not structural, and using cognition, you need to use these subtle measures of generalization, not the standard. So not structural MRI, not the standard neuropsych, if you want to see any of these sort of subtle relationships going on in a cognitively healthy preclinical population. So what's our most important messages to leave you with? One is that demographics is not destiny. And two is that genetics is not destiny. And to best capture this concept that demographics is not destiny and genetics are not destiny, we turn to the East Orange Senior Center Silver Steppers. These ladies range in age from 80 to 92, and I share them with you. They perform at most of our community events. Most of them are participants in our study, and they are role models for healthy aging.
Hey, you might notice back in the day. I'm here on the floor. Together, y'all.
So at 92, we should all be up on stage dancing like that. So in closing, I want to find two final invitations. One is in September, we're organizing with Hebrew University and Tel Aviv University a U.S.-Israel Alzheimer's conference. The goal is to expand and strengthen collaboration between U.S. and Israeli scientists seeking a cure for Alzheimer's. We have many generous donors who have contributed, and we have a number of fully funded student travel fellowships with an application deadline of June 15th. And we have flyers that I will pass out to the 4 people here in this office with me and others. And we hope to see a lot of applications and send students there. Another application, some of you in the audience were at our first interdisciplinary conference tutorial workshop on aging and brain health in Aspen. The next one is in January 2025. This is a very different sort of conference. It's not about presenting your work. It's about broadly accessible short tutorials. It's about sharing your expertise with someone in another field. We all hear about interdisciplinary research, and everybody wants to do interdisciplinary research, but then you go to a talk at a field outside of where your PhD, and you can't understand what the hell they're talking about. So this is really about learning about other people's fields and getting tutorials, sort of TED Talk-like tutorials. Again, we have money for fully funded student travel fellowships because these sort of small workshops are really where careers and networking and made. So if any students are interested, they can see our website. The talks are from 4 to 7 p.m. and it's located at the base of Snowmass Ski Resort. So it's very small, 50 people max, and people ski all day, or they snowboard, or they go explore the mountains or the city. And then we have several hours of these short 15-minute TED Talk-like tutorials. I encourage you to come and live brain healthy and learn about brain health. And for more info, this is my website, my email, and that brings me to the end of the talk at 40 minutes.